Hello, everyone. On behalf of York Hospital, I'd like to welcome you to today's webinar. Today, we're fortunate to share some time with York Hospital's talented infection control team, Dr. Evangeline Thibodeau and Dr. Gretchen Volpe, who will advise us all on how we can better manage the flu season, the ongoing pandemic, and the stresses we're generally met with as winter and the holidays approach. Before getting started, we do have a few quick housekeeping notes to review with you. Unlike traditional Zoom, where you see everyone's faces during the meeting, during this webinar, you will only see the presenters' faces and slides. As participants, your audio has been muted, so if you do have a question, you should type it into the Q&A button located on the bottom of your screen. Please do not use the chat or the raise hand icons, as those will not be monitored during today's presentation. If you ask a question through the Q&A feature and it is not answered during this meeting, please feel free to email us at info@yorkhospital.com and we'll reply after the webinar concludes. Additionally, today's webinar is also being recorded and will be available for viewing on York Hospital's YouTube channel early next week. So once again, thank you very much for tuning in today and spending this time with York Hospital. We hope you find the information helpful, and we're pleased to get started by turning the program over to Dr. Volpe. Thank you, Dr. Volpe.
Sure, thank you. So today we're going to talk about a couple of things. First, we're going to overview some infectious respiratory diseases that occur in the wintertime, such as RSV, influenza, COVID, and some other respiratory viruses. Then we're going to talk about some how infectious respiratory diseases were last winter. Then Dr. Thibodeau is going to talk about COVID-19, the virus of interest today. And then we'll talk about how COVID-19 may affect some of the infectious respiratory virus illness diseases this winter. And then we'll talk about vaccinations, routine vaccinations, influenza, and COVID. Next slide, please. So I just wanted to remind everyone that there is seasonalities to some respiratory viruses, and there's a variety of factors that cause certain viruses to be prominent at different points in the year. So there's seasonal factors such as temperature, humidity, sunlight, and vitamin D status. There's also some changes in host defenses, the host in this case being people, including antiviral immune defenses in the airway and the efficiency of mucociliary clearance in the airway as well. Also, there's changes in the indoor environment, including temperature and humidity. There may be some changes in the virus transmission dynamics as well, such as sizes of droplets, etc. And then there's human behavior. So people being indoors, holidays, different types of social behavior and different hygiene practices, also school openings as well. And these factors impact the seasonality of respiratory viruses. Next slide, please. Some common respiratory viruses that circulate in the winter include influenza, respiratory syncytial virus, which we call RSV, parainfluenza viruses, metapneumoviruses, rhinoviruses, coronaviruses, adenovirus, and bocaviruses. So when people say I have a viral upper respiratory infection, it can be any of these infections, and they have a variety of different syndromes that they cause, including upper respiratory tract infections, croup in children, bronchitis, pneumonia, etc. And we usually use PCR antigen detection or culture to find these viruses in clinical samples. Next slide, please. This slide just sort of accentuates which viruses are most prevalent during which seasons. So if you look at the top three lines, the winter viruses, you see influenza peaking in the January, February, human coronaviruses, February, March, and RSV in that December, January period. Adenovirus and bocaviruses are found all year round and contribute to common cold syndromes. Parainfluenza viruses, depending on the type, have different seasonality. And then spring is more common for human metapneumovirus, and spring and fall for rhinoviruses. There are also summer viruses such as enteroviruses. Next slide, please. Just a word about RSV because it impacts children and is frequent in the winter. So this is the most frequent cause of lower respiratory tract infection leading to illness and death in children worldwide. Most children have been infected by H2 and can be reinfected throughout life, which is common. There are seasonal outbreaks in the winter and early spring in temperate regions like ours, and then in the rainy season in tropical areas, and this is felt to be due to crowding indoors. Transmission requires close contact, so frequent cases in family members is found. And many children with RSV require medical attention and some require hospitalization. About 10% of all children have bronchiolitis in the first year of life, and most of those are due to RSV. So it's important to remember this virus in children in the winter. Next slide, please. I wanted to highlight some similarities and differences between influenza and COVID-19, as those are going to be two predominant viruses in the winter that we will deal with. Both can cause similar symptoms such as fever and chills, cough, shortness of breath, sore throat, congestion, headache, and they can cause some intestinal symptoms like vomiting and diarrhea and changes in taste and smell. They're both spread from person to person, mostly by inhalation and to a lesser extent by contact. And people who are at higher risk for becoming ill from these viral infections include people who are older, people who are pregnant, and people with underlying medical conditions. There are some differences between influenza and coronavirus 19. The time of onset tends to be shorter for flu, 1 to 4 days, versus the average time to onset of symptoms rather for COVID is about 5 days. However, the duration of possible time of onset is longer than with influenza. In terms of the time period that a person can be contagious, for flu, it tends to be a day before illness symptoms start rather to about 7 days afterwards, although this can be longer in infants and in people with immunocompromising conditions. For COVID-19, spread can occur for 2 days prior to onset of symptoms to potentially 10 days after onset of symptoms. This may be longer, it's still being investigated, and it's been shown to be possible to transmit COVID for after 20 days from onset of symptoms if a person is severely ill or immunocompromised. So that's sort of a major difference between those two viruses. COVID is potentially more contagious and lends itself to super spreader events a little more than influenza has been seen to do. And it may appear to be slightly more severe, even in otherwise healthy people. And the second thing that's a little bit different in terms of severity is this multi-system inflammatory syndrome and some of the post-COVID conditions that are not typically seen with influenza. Next slide, please. So what happened last winter, 2021, 21, wow, can't get that out, winter season, is that influenza activity was unusually low, both in the United States and worldwide, even though testing for influenza was quite high. So for comparison, 0.2% of respiratory specimens in the United States were positive for influenza in this past winter season versus typically 25 to 30% in the last 3 seasons. So that's a very big drop, a very big difference between those seasons. There were also many fewer flu illnesses, hospitalizations, and deaths. So the cumulative hospitalization rate for flu in the last season was the lowest recorded since 2005. And there was only 1 pediatric death reported. This became a reportable event since 2004, and typically the number of pediatric deaths per season are 37 to 199, and there was only 1 last season. We think that the reasons for the reduced influenza activity this past winter are predominantly COVID-19 mitigation measures, meaning the social distancing, masking, etc., and increased flu vaccine distribution, which was the highest it's ever been. In terms of flu vaccine rates last year, more adults were vaccinated compared to the previous season. A slightly lower rate of children were vaccinated, but there persists racial and ethnic disparities in vaccination rate, and that may be important for the following influenza season. Next slide, please. So now I'm going to turn it over to Dr. Thibodeau to talk about COVID-19 issues.
Thanks, Dr. Volpe. So I wanted to go over COVID because it's obviously the elephant in the room, and what's going to happen over the next winter as we know with COVID. So I'm going to go through some statistics on local case rates, hospitalizations, looking at some vaccination rates. And then I want to talk about some specifics because I think it's important to highlight what we've learned and how that helps us predict what's going to happen in the winter. And everything I say in terms of prediction is, we've been fooled so many times before, not me personally, but a lot of models out there. There's been a lot of surprises with COVID. So I don't think anyone can truly predict what's going to happen. But I think if we look back historically, we can see where we have learned a lot of information and how we can kind of extrapolate from that. So I want to talk about variants because that will determine a lot of what our future holds. The lessons we've learned with schools, talk a little bit about vaccines, and then again, these predictions and paths going forward. Next slide. So to take a step back, this is over the past 20 months. And I think it's important to take a step back because we're at month 20 now. And I think we've all just been fatigued and kind of lost where we are. This is the national statistics of cases. I didn't go through hospitalizations, but it follows a similar pattern in terms of the activity in our country. So this is from the CDC COVID Tracker. They have a lot of data out there, and you can see pretty clearly that early on we had a wave in the spring of 2020. We certainly weren't testing as much at that point. So the variables change as we go through the months, but we can clearly see that we've had peaks and valleys in COVID activity nationally. Next slide. And then this is Maine, and we can see right now we are currently still, and all of this data is ending of last week. So this is as of October 15th or so. We can see in Maine, we clearly have had some peaks and valleys of COVID activity, and we're actually currently still in a pretty high active COVID level compared to what's going on nationally. It's hard to say if you can look at this data so much more easily in retrospect, and it's hard to say if we've peaked, if we're plateauing, if we're coming down. I think just time will better explain what's happening now. So next slide, please. This is the famous red map that everyone talked about last summer. And I think this map was, it was really put out there by the federal CDC to try to assess the level of transmission that's going on in your community. We look at this as healthcare professionals to make decisions on how we're going to infection control practices in the hospital, and how we're going to change the way we take care of patients if needed. And so this was put out there by the federal CDC, but it was also put into the public in terms of how you can assess the level of transmission in your community. And they broke it up into 4 categories of high is the highest level of community transmission and being in red, and low is a relatively low level. And they look at a couple different factors to determine what level of community transmission you're in. You can go on to the next slide. So this is York County, and let's move my Zoom here. So they look at a couple things. The positivity rate that you see there is 6% last week. That's one of the things we look at. It's helpful to look at this once a week because you can look at it every day and it changes probably a little bit every day, but it's helpful to look at it once a week to see what trend that is going. And again, this looks at the level of community transmission in your county. So you can go into the COVID tracker on the federal CDC and you can plop in your zip code and look at your positivity rate, and it kind of tells you what is going on in your community at that time. Next slide. So let me just have to move my pointer there. So I want to talk about variants a little bit, because you hear a lot about variants and what does that mean, and alpha, delta, wild type, all these different variants, the mu variant that's been out there. So variants are actually expected. Viruses like to mutate because they want to be more fit, and they want to survive our host mechanisms to try to decrease that we're trying to eliminate the viruses, but they're trying to kind of capture more people to infect. That's how they survive. They survive off infecting other hosts. So they really are expected. These viruses are smart, and they are always constantly trying to change to evade our natural immune defenses. The CDC monitors these variants, and they categorize them as variants of interest or variants of concern. And what really, from the community standpoint, is what you need to know is the ones that are really important are the ones that are more infectious, like Delta, that I'll talk about, ones that can evade our natural or vaccine-induced immunity, and then ones that can also evade our current testing platforms. And those are significant, these three factors, because that could change the wave of how the pandemic is going, and that may raise alarms in terms of how we recommend vaccines or change mitigation strategies. There are certain recommendations that the CDC might make. They watch these three factors very closely when they're monitoring new variants. So there's tons of variants out there that they're monitoring, and those are the reasons why. The best way for us to prevent new variants is really to decrease the spread. So the more people the virus has to infect, the more opportunities it has to try to evade those natural defenses, or have meet one of those bullet points above. So really just decreasing the spread is going to decrease the emergence of new variants. So the Delta variant is the current variant, and what makes it so unique is that it's so much more infectious than prior variants. The previous variant was Alpha, which was the dominant strain, and prior to that, we had more of the wild type strain, and Alpha was more infectious than the initial strain. And it makes sense because these viruses want to be the survival of the fittest. So Delta is going to outweigh Alpha because it's just that much more infectious. But currently our testing platforms and our vaccines actually work quite well for Delta. So really the unique feature is that, where previously one person may infect 2 to 3 on average, infect 2 to 3 other people, now you're talking about one person may infect 8 people or so. So that speaks to the infectiousness of this virus. Okay, next slide. So I want to talk about schools because it helps us see how far we've come in learning a novel virus and how we are kind of moving forward. So as you all recall, in March of 2020, pretty much every school in the United States shut down, along with many other mitigation strategies. And this was in response to obviously the pandemic, but that most respiratory pathogens, influenza, RSV, they do contribute a lot to transmission, and they can cause, not so much super spreader events, but they can be major spreaders in infections and cause outbreaks, and then that bleeds into the community. Whereas what we learned over time, looking in year 2020 to 2021, the schools returned, and they returned mostly in a remote or hybrid model. And most often we saw that that schools were not involved in major outbreaks. So children certainly can be infected with COVID, but they weren't the main driver of transmission. And that was one of the reasons why schools opened in 2020 through 2021, is they felt that from the limited data they had at that 6-month point, that they felt that it was relatively safe to do that, proceeding with caution, opening in a hybrid or remote model. So the data from that year, they found about a secondary attack rate was about 1%. And that was in a lot of studies, observational studies. They saw, with a lot of mitigation strategies in place, they saw that if one person came into school infected, on average about 1% of the cases in the class in that building were subsequently infected. So that was relatively low, and they felt that that was something that was possibly tolerated. So then that brings us to this year, the 2021 through the 2022. The focus really is on in-person learning, because you balance that, secondary attack rate with the needs of in-person learning and the mental health crisis that's going on with the children right now due to the pandemic, and the focus was on in-person learning with proper mitigation strategies, such as masking. Testing has been a big part of some of the strategies now that there's been more available testing, such as pool testing. So that's been really the focus this year, and it's very early on, but if you look at Delta data, they are showing that these mitigation strategies are still working. And I didn't put the secondary attack rate in this school year, but there has been some very, very early studies that show that this is about the same, that it's still about 1%. So relatively, not going to say zero, but relatively safe place for these schools to stay open, trying to keep the kids in the classroom. So really that's been the focus. So going forward, these mitigation strategies are really emphasized to try to keep kids as healthy as possible, balancing that with the in-school instruction being more of a benefit than more remotely. Okay, next slide, please. So how do we prevent COVID? And I really like this slide. I've used this in a few other talks before because I think you could use this for really any respiratory virus, but prevention, it's not just one tool. We have a lot of different tools, and there's a lot of holes in each strategy that we use. So the combined layered approach is how we're going to really give ourselves the best prevention. And it goes from everything from masks and hand hygiene to testing to, the advent of vaccines, almost a year now that we've had in the population. And all of these really together is really going to give you the best, put you in the best position to prevent yourself from getting sick. Next slide. So I'm just going to go briefly through the vaccines. I don't want to spend too much time, but it is one of the biggest pieces of Swiss cheese that we like to focus on when we talk about the mitigation strategies, because these vaccines are so effective. We were so lucky to have these vaccines available early on in the pandemic and how much they changed the trajectory. So in the United States, we have 3 vaccines. The Pfizer has had a full FDA approval, and then the Moderna and J&J are still under emergency use. The Pfizer and the Moderna vaccine are 2 doses of this mRNA novel technology, 3 weeks for Pfizer, 4 weeks for Moderna. Their effectiveness, so we look both at clinical disease and hospitalization, and the effectiveness really combined over time at 6 months is still about 6 months. It's still about 90%, but then starts to wane. Certainly for clinical disease, we know for hospitalization and death that these vaccines are excellent and still holding up pretty well to hospitalization and severe illness. I mean, they might be decreasing a little bit, and that's what's been advocated for the booster vaccines. So side effects for the Pfizer vaccines, really little. The anaphylaxis is the big one that we have we caution for, and then the myocarditis is really unique to the mRNA vaccines, and overall risk is about 5.8 per million. Certainly this is a little bit higher in the younger men. That's the population that has been identified as higher risk of developing myocarditis from the mRNA vaccines. The J&J vaccine is also a novel technology, an adenovirus. It's the 1 dose. Efficacy is a little bit less, more 60 to 70%. The major side effect with the J&J is the cerebral venous sinus thrombosis. This is blood clots. This overall risk is quite low, 2 per million, a little bit higher in women, ages 7 to 49. So the 3rd dose versus boosters, I just want to kind of clarify what the difference is. Dr. Volpe is also going to go into some of this as well. But in August of 2021, the FDA and then subsequently the CDC recommended that people who are severely immune compromised get a 3rd dose of an mRNA vaccine. And that's really just to get to the same playing level ground as the non-immune compromised folks. So it was really almost to complete the vaccine series, they needed a 3rd dose. And that's because their immune systems just don't mount as robust of a response as immune competent individuals. So that was authorized in August, not really any specific guidance against J&J, but that data is coming. So now when we're talking about boosters, that's a little bit different. So some of the data is showing that the efficacy of the vaccines are waning over time. It doesn't appear that that Delta has been a variant of concern that has evaded our immune response. It doesn't appear that way. It seems more that it's a waning, possibly a small combination of both. hence the recommendation for boosters. In September, those who had received Pfizer were recommended to get a booster shot 6 months after their second if they fell in a high-risk category. So those are folks who are older than 65, high-risk medical conditions, or had a high-risk exposure, such as frontline healthcare workers or teachers. Moderna and J&J, I did finish the slides last Friday, prior to the full FDA, has recommended that boosters proceed with these groups as well, but the details are to be determined later this week, so stay tuned for that one. Next slide, please. So predictions, this is like my magic crystal ball that Dr. Volpe and I get asked almost weekly what's going to happen, and really nobody can say with complete confidence what's going to happen. So what I can say is that we've kind of been in a pre-COVID versus post-COVID area. We know we're not really ever going to go back to our pre-COVID area. I actually try to look at the silver linings of this pandemic on a personal and professional basis frequently, and I find that the public is much more educated about viruses and transmission and masks and all of that in general. So a lot of people have just more general knowledge of what our daily lives are like. So with having that knowledge, I think people can be better prepared, such as coming to talks like this, to kind of navigate the post-COVID world. Variants is certainly, I brought that slide up before, it's certainly something that's going to play in the future. If we develop a variant that evades our natural defenses or evades our vaccine protection, that's could totally change the pandemic completely. It's hard to say what variants will arise in the future. The waves, like I showed you the graphs at the beginning, the waves have really been about 2 to 3 months. And so I think that just points that there's a lot we don't know, and there's a lot we're still learning. Why does it last 2 to 3 months? It's not just all seasonality, like Dr. Volpe talked about, that we come inside. Why did we have a wave in New England starting in August when a lot of us were outside already? I think there's going to certainly be pockets in regional activity, and a lot of that does depend on our vaccination rates as well as the global vaccination rates. So this is, as most people know, these viruses can cross borders. So that's kind of infectious disease 101, is that they don't care about geographic borders or political borders. These viruses just can go everywhere. So we really need to have global vaccination rates high to prevent new variants and to really kind of get through the cases that we're seeing now. And then vaccine hesitancy is a huge one. So that's something that in the healthcare setting we try to address on a daily basis. So these are kind of all the variables that go into what does our future hold with COVID. So next slide, please. So having said that, there are some models out there and there are some forecasts. Again, on the CDC, you can check this out. You can put in, you can go down to York County. This is the national forecast, and they look at about, it's about 30 to 40 different models, and they conglomerate it all together and they make predictions over 4 weeks. So what's going to happen in the 4 weeks? And I have to say, I look at these and they're, they've actually been fairly accurate. We always interpret models with a grain of salt, but it does seem that over the next, into November, the next couple of weeks or so, we're going to be going down. Now, this is on a national level. I didn't put it up here, but York County, it does appear that we're kind of more plateauing, which would go along with some of those slides that I showed at the beginning, that it's hard to say, are we peaking? Are we plateauing? Are we going down? So over the next couple of weeks, it seems like we're probably just going to stay at our current caseload, not really going up too much, but that helps us in the healthcare setting to determine, what to be prepared for over the next couple of weeks. So interpret with a grain of salt, but again, you can go in and put your zip code and look, or anywhere you're planning on traveling, and looking what their case rates are along with your national map. Okay, next slide, please. Dr. Volpe talked about this, but I just wanted to bring it up again about looking at what happened last year and looking at flu. We had the flu activity is in the black lines, and we had absolutely no flu last year, which again is probably due to all those mitigation strategies. But it's hard to say, what's going to happen this year, but it looking at last year, we certainly really had no influenza last year, but look at some of the other viruses. So RSV, I think everyone was surprised that RSV, it's a winter virus. All of a sudden last summer, we had a huge spike in RSV and we're still seeing a lot of it. So I don't think anyone can really predict that. So there's going to be other things that are going to happen that we just will kind of not be surprised by. So maybe we'll be pleasantly surprised by some of these things. So I think we were with influenza last year, and then it's hard to say what's going to happen this next year. So next slide, please. So what I'm kind of getting at is this dreaded twindemic, and we talked about this last year. Are we going to have influenza and COVID at the same time? And the major concern here is healthcare systems. Are we going to overwhelm our healthcare systems? We always see more respiratory illnesses and subsequent hospitalizations in the winter seasons. So if we have COVID on top of that, what's going to happen to our healthcare systems? And remember, when we talked about COVID at the beginning in March of 2020, the whole point of the stay-at-home orders and the mitigation strategies was to save our healthcare systems from collapsing, because we needed to take care of not just COVID patients, but non-COVID patients as well. So that's the big buzz right now, is what's going to happen this coming winter. This was the buzz last year this time, and we were pleasantly surprised last year that we had minimal flu, but we still had quite a bit of COVID, but we're fairly well in most regions. We're able to take care of COVID pretty well because we didn't have flu on top of that. So the concern for more flu activity this year, though, is because we had so much little immunity, so much little activity last year, that some of our natural immunity from that will not, we won't have much. So each year we get an influenza vaccine to try to capture the slight variants of the influenza virus that's circulating that season, but we do get some immunity from previous seasons, but we don't have that this coming year. Certainly there's fewer mitigation strategies that will be happening this upcoming winter, with mask mandates and more kids in schools, more people in the office, more people traveling. So that's the big concern for this upcoming year. So if we look at the Southern Hemisphere, kind of what's happened in some of the areas that have already had their flu season, the CDC does track activity. And if you look at 3 countries, South Africa, Argentina, Australia, their cases were still below their activity this past year was still below their averages from the previous 8 to 9 seasons. So that may give us some insight. It's just one kind of data point people look at to see, can we do any kind of predicting of what's going to happen? But it's hard to say. We're just not quite sure yet what this upcoming winter season will hold. So next slide, please. This is, again, this is all in the CDC. They look at, respiratory illnesses. They have a great flu tracker. You can look each week, and they have some great visuals there if you're interested. And this looks at the past few years. You can see that flu was in yellow, and again, minimal number of flu, but look how much COVID we had over the past 20 months or so. This will continue to go over time, and you can kind of follow this trend to see what levels of flu and COVID are happening, and you can look in your regional area as well. Next slide. So this is flu activity so far this year, and it's still below average of what we've seen in previous seasons. So we're still kind of starting off low, which is a good thing. We're just not quite sure how high it's going to go, and time will tell. So I think that's my last slide. I think I'm going to turn it over to Dr. Volpe to finish it up.
Thank you. So I wanted to mention the vaccines that are recommended for healthy adults with no major medical comorbidities. That includes, this season would include the flu vaccine and the COVID vaccine, and those can be given at the same time. In the past, when the COVID vaccines were just coming out, there was a recommendation to avoid administration of other vaccines around the time of the COVID vaccine, but that has subsequently been removed, and now you can receive any other vaccine along with the COVID vaccine. The annual flu vaccination is recommended for everybody who's over 6 months, with very few exceptions, which I'll mention in a little bit. Most people should receive their influenza vaccine in September and October, and all persons are recommended to have completed influenza vaccine by the end of October. If you're over 65, the recommendation is not to get the vaccine earlier than that due to concern for reduced immunity towards the end of the influenza season. However, earlier vaccination may be indicated for people who are in their third trimester of pregnancy to make sure they're protected by the time they deliver the infant, for the protection of the infant. And also earlier vaccination can be given to children, especially those who need 2 doses as part of their initial influenza vaccination requires 2 doses. The third COVID dose is recommended for those with certain medical conditions and in certain settings, as Dr. Thibodeau mentioned before. Could you advance the slide, please? So briefly, exceptions for influenza vaccine. So people who should not receive influenza vaccine include children under 6 months of age, those who've had severe life-threatening allergies to any ingredient of the flu vaccine other than egg proteins, such as gelatin, antibiotics, or other ingredients that are in the influenza vaccine, and those who've had a severe allergic reaction to a previous dose of influenza vaccine. People who should really talk to their healthcare provider before getting an influenza shot, because you may be perfectly able to receive an influenza vaccine, perhaps of a different type than what you'd had before, would be people with allergy to eggs or non-severe allergy to other ingredients of the vaccine, anyone who's had a history of Guillain-Barré syndrome, those who've had a severe allergic reaction to a previous dose of a specific flu vaccine, because it may not be relevant to other types of influenza vaccine. And generally, if you're not feeling well, it's recommended typically not to receive an influenza vaccine, as you may not respond quite as well to it if you're fighting some other kind of infection. Nasal influenza vaccine, because it's a live virus vaccine, has other exceptions for administration, and so you'd want to talk to your doctor before receiving that. Oh, could you advance the slide, please? So the third dose, which is a booster dose, this is separate from the third dose recommended for immunocompromised persons for all mRNA vaccines. But the booster dose for Pfizer only currently has been approved for adults over 65, adults over 18 and over rather, sorry, with underlying medical conditions, some of which I've listed below, adults 18 and over residing in long-term care settings, or adults 18 and over who work or reside in certain occupational or institutional settings that makes them higher risk for acquiring COVID and or disseminating COVID, and healthcare, schools, correctional facilities, homeless shelters. Those would be examples of that. As we mentioned before, the third dose of Moderna is indicated for severely immunocompromised persons, which is separate from a booster dose. As Dr. Thibodeau mentioned, the FDA and the CDC are working on recommendations that will probably recommend a third dose after 6 months, or a booster dose for Moderna vaccine recipients, and potentially a second dose for J&J recipients. Next slide, please. Immunocompromised persons should certainly get the influenza vaccine, the COVID-19 vaccine, 3 doses if mRNA vaccine is given. But they should also remember that there are other vaccines that may be indicated for them depending on the immune-compromised situation. So most would require the 2 pneumococcal vaccines, which is Prevnar, PCV13, and Pneumovax, PPSV23. And some individuals with certain immunocompromising conditions may also require the Haemophilus influenza and or meningitis vaccines. So if you have an immunocompromising condition, certainly talk to your doctor about what vaccines you might need to get you up to date. Next slide, please. For pregnant women, the important vaccinations are influenza, inactivated only, COVID-19 with the third dose after 6 months if Pfizer is utilized, and the tetanus, diphtheria, and acellular pertussis vaccine, or Tdap. There are some contraindications for certain vaccinations in pregnant women, but these are the 3 vaccines that are really recommended. So certainly talk to your doctor with other questions about that. Next slide, please. For children, influenza vaccine is recommended, 2 doses if it's the first time receiving the vaccine. COVID-19 vaccine is currently approved only for age 12 and older. We may see some approval for younger ages over the next few months, but that's to be determined. And then it's important to make sure that children are up to date with their routine immunizations. As some children over the course of the pandemic have missed some of their routine vaccinations because of delay of care or avoiding interaction with healthcare during the pandemic. Next slide, please. So in summary, some of the ways we think that you could utilize to stay healthy this winter include making sure you're vaccinated and encourage others to be vaccinated as well against COVID-19. Continue some of the COVID-19 precautions that have really helped with COVID-19, but will also help likely with other respiratory illnesses such as influenza, and that includes hand washing, staying at home if you're sick, keeping your distance, avoiding crowds, things like that. Certainly being alert for symptoms and being tested for COVID-19 and or influenza as recommended by your provider if you develop any symptoms, and really being cautious to pay attention to your symptoms no matter how minor they are so you can avoid spreading COVID-19. Also be aware that there are certain people who are more vulnerable than others, and really being cautious about protecting those vulnerable people, such as immunocompromised persons and people who are ineligible for COVID-19 vaccine, such as under 12-year-old children at this point. That's a very important part of community health. And then travel considerations. So recognizing that the spread of COVID-19, the transmission of COVID-19, the case numbers of COVID-19 may be different if you're traveling to a different place, either within the United States or internationally, and to be mindful of that. And also, there's a different flu season in the Southern Hemisphere, and also some of the other respiratory viruses have different seasonality depending on the tropical or temperate climate. Next slide, please.
Thank you, Dr. Volpe and Dr. Thibodeau. We received two questions in advance, and perhaps Dr. Thibodeau, you could answer this first question since you presented some data earlier in this presentation, and then Dr. Volpe, the second question about long COVID, you could take, and we have a question in the chat that we'll address at the end of that.
Yeah, so I can read the question out. Reporting of active case counts and hospitalization rates have helped us understand the level of COVID in our community. My concern is that public reporting will eventually stop as the Delta variant reduces, and we will not know when or if local community surges occur. Will local Maine public health authorities tell us when to mask up again for this in-between time while we wait for Delta and COVID to truly be eradicated in our community or become endemic? So I think that tracking is not going to go away. I think we are, as I showed in a lot of my slides, there's, national flu trackers that they track every single year. And I predict that the same will happen with COVID, that we're going to continue to track COVID on a local as well as national, as well as international level, certainly for the foreseeable future until, maybe we get it to some sort of virus like measles that we only see every once in a while. So when that happens, we're not sure. But I do not anticipate any that we won't be tracking COVID. We do have some York Hospital specific COVID data as well that is very similar to what's going on in York County. So I would be comfortable saying that we're going to continue to track this for the foreseeable future. In terms of masking and mitigation strategies, this certainly has been a bit controversial in the sense that people felt that once, I can use Maine as an example, when we were under the state of emergency, which was ended in June 30th, there was some political power in terms of enforcing some of these rules that we had in place. And when the civil state of emergency was lifted, some of those recommendations or mandates were also lifted. So back to that red map that we talked about, that kind of gives you an indication of the level of community transmission going on in that region. And that specifically that guidance was actually put out in terms of the recommendation of when to use indoor masking. So outdoor masking is not recommended in general unless it's a very crowded outdoor event where there's a lot of people crowded in the small area, but that that national red map that I showed kind of early on in my talk was intended to guide people about the level of community transmission going on, and if it was wise for them to mask inside in addition to being vaccinated. The recommendation is to be vaccinated. So in addition to being vaccinated, you should still mask if you're in these red or orange zones, because there's still high level of community transmission going on. So that was the intention for that map, is to kind of give that guidance. And it seems that data being collected, we're going to continue to have that guidance going forward. So, it's a tough one. You don't just look at the case rates. You also want to look at what kind of activity you're doing. People ask Dr. Volpe and I these questions all the time. Would you go to this birthday party or graduation or this kind of celebration? And it's all about your personal level of risk and, what people, you yourself may not be at risk, but maybe you interact with other people that are at risk, or maybe there's unvaccinated people in your household. So all of these things, you can look at your case rates, but you can also kind of look at your individual risk perception, and you got to kind of factor all those things into play. I think we've all gotten really good at this. And yes, it can lead to a lot of anxiety in terms of how you perseverate over these decisions, but ultimately it comes down to a personal decision. Masking in general, we say, is always recommended indoors, certainly at this time with high levels of community transmission wherever you are. Maybe we go on to the next question. Great.
Okay, what is being done locally to prevent and address care needed for current and future long COVID patients? So in terms of prevention, the best prevention we have at this moment, even for people who've previously been infected with COVID, is vaccination. So vaccination is recommended even if you've had previous COVID infection, even if you're suffering from some long COVID symptoms, to prevent future infection and future symptoms. So prevention is really what we've discussed: vaccination and the other mitigation measures to prevent infection that we've talked about in the the Swiss cheese model. So care. So there are several manifestations of long COVID. Some patients continue to have what we call olfactory or gustatory symptoms. Gustatory maybe is the correct way of saying it. Symptoms, which means loss of taste and smell, or differences in taste and smell, changes in taste and smell. And so for those patients, they may require referral to ear, nose, and throat, for example. There are some online, actually, smell scent training programs for those patients as well. And those are kind of the first steps, but it is sort of specific to those symptoms. Other types of symptoms have been cardiopulmonary, or problems with lung function and cardiac function and exercise tolerance. And for those patients, follow up with a pulmonologist or cardiologist with appropriate testing, and then appropriate referral either to in-person rehabilitation, outpatient or inpatient, or there's even some telemedicine rehabilitation or tele-rehabilitation programs that can be helpful for that. Another type of long COVID symptom includes neurocognitive symptoms, so neurologic, including confusion, brain fog type of symptoms. And there are some facilities that do have sort of rehabilitation programs for those kinds of long COVID symptoms as well. Locally, most of those are a little bit further afield than York County. So Massachusetts General definitely has the COVID rehabilitation programs. And so I think it's the symptoms of long COVID, the diagnosis and treatment of long COVID is really evolving, because this is still quite new. And so our understanding of long COVID is going to keep changing. But that's sort of where we are at the moment.
Thank you, Dr. Volpe. And we do have one of the questions that was submitted was, I think, Dr. Thibodeau, you did kind of address it in your answering of the first question, but is there any guidance that you can offer to the people on the line about the maximum number of family or friends that could gather indoors this holiday season and with children who are not yet vaccinated?
I don't think we can put an exact number on it. I think in general, what we're seeing is if you're vaccinated and you're not severely immunocompromised, you should feel pretty good about yourself being very well protected against severe disease and illness. So obviously we get vaccinated not just to protect ourselves, we do it to protect the general public and to protect our, family members or other people we're going to be, or maybe the ineligible, like the children under the age of 12. So then it's kind of goes to that personal risk assessment of if you're going to be around someone else who's unvaccinated, what's your risk to them? Or the other question would be, what's their risk to you? So there's kind of two scenarios here. So let me back up one moment and say that a vaccinated person certainly can if they can get infected, they can have what's called a breakthrough infection. It's not common, but it does happen. They can go on and they can transmit it to other people. And the higher likelihood is for them to transmit it to an unvaccinated person. We do see it, but vaccinated individual transmitting to another vaccinated person is pretty rare because it's kind of two rare events. So when you say, how many people could be in a room, I would say how many vaccinated people can be in a room. So the more people that are vaccinated in that room, the numbers and the odds are just so much lower. So what we tell people who have people who are ineligible for vaccination, you just got to bubble yourself around as many people that are vaccinated as possible if you're going to be doing something that you think is outside of your essential activities such as school or work. So again, it kind of it speaks to that. I would say not the absolute number. I would say the number of vaccinated people. I can just tell you on a personal basis that it's kind of one of my questions now. If I'm meeting someone new that I feel is more of a social situation, I make sure they're vaccinated before I interact with them, because I feel that, I don't want to put my patients at risk or some of my family members that are ineligible for vaccination at risk. So it's one of those things that I think it's sad that it's become such a political question, but it is such an important health question to ask, because it is a direct implication in terms of how the risk perception and how you're going to make decisions going forward. So that would be my answer to it. Sorry for the exhaustive response.
Not at all. Thank you very much for your response. And we do have one other question. Perhaps Dr. Volpe, you'd like to take it. Is there any proof that there are certain blood types, or there is a certain blood type that does not get as serious disease of COVID-19 as others?
Oh, geez. I remember hearing something about that in the beginning, but I don't feel that that's been borne out. It certainly hasn't made an impact in our clinical world or epidemiologic world to change our management or change our way of approaching it. So I don't think so, to my knowledge.
Thank you. Well, we would encourage anybody who's on the line that would like to ask a question. We would just remind you that you can type that into the Q&A button located at the bottom of your screen. We can hang on the line for another minute or so to see if you have any unanswered questions. Let's just see. We'll take a look at that Q&A button. And if there are no further questions, we appreciate the time that you've all spent with us today, and we do appreciate your time as well, Dr. Thibodeau and Dr. Volpe. Thank you very much for all the information you shared. And we just hope that you found the information educational and enjoyable, and we hope you enjoy the rest of your afternoon. Thank you very much from York Hospital.